أشكر دكتور وائل الشاعر أولاً لاحتضان الحروب في المؤتمر اللي فات والمؤتمر ده وبالشكل ده بالشكل المالتي ديسيبلينري اللي فيه كذا تخصص مع بعض، إن ده نجاح أي وحدة قانون والاوتكم بتاعها بيبقى ريليتد كذا ممبر من التيم، مش شخص واحد اكيد مش هيجرب بعض. This is the second time we're presenting as a team. I have nothing to disclose. أول مرة كان في مايو في بنسويف. It was a very good experience, and for us it was the first time to present as a team. And just the fact that we presented as a team improved how we communicate مع بعض from me لدلوقتي. So I'd like to thank دكتور وائل للحاجتين دول and for the invitation طبعا. We all know that historically and unfortunately لغاية دلوقتي في بعض الأماكن burn scare is neglected. The World Health Organization calls it the forgotten public crisis. البيرنز أكتر في أماكن low socio-economic ما فيهاش resources وفي نفس الوقت بتأثر socially financially. ممكن نصور؟ يا باشا اتفضل. Socially and financially على العيانين. And unfortunately they don't have anybody to take care of them yet. لما بنتكلم عن المالتي ديسيبلينري تيم اللي هو الثيم بتاع الميتنج ده كله، هي مش فكره جديده، يعني طبقت من زمان اكتر في الانكولوجي في الاول وmaybe in other disciplines، بس دلوقتي actually it's one of the requirements for verification of burn centers and is in the guidelines بتاعت multiple burn organizations and in the International Society of Burn Injury guidelines. It could be done. It doesn't need money. It needs cooperation and needs communication and finding the dedicated staff. طبعا الفترة اللي فاتت في ادفانسز كتيرة قوي حصلت في البيرنز وكل شوية بيحصل ادفانسز، ولكن الجزء الجراحي صغير قوي. Early excision and coverage. The rest of the advances are all related to the rest of the team, other disciplines. And that's why احنا في القصر العيني we work in this pattern, in the cartwheel pattern. للأسف معناش الشخص اللي في النص اللي هم النيرسز. I must say ان هم اللي بيشيلوا العيان واهله وغياره وقرفه، and the outcome is directly related to the nurses. So I'd like to thank our nurses هم مش معانا النهارده للأسف. فزي ما قلنا major burns are beyond the capabilities and the knowledge and the expertise of the surgeon. في حاجات كتيرة قوي احنا ما بنعرفش نعالجها وبنعتمد على the rest of the team. For example, بنعتمد على resuscitation fluids اللي ما يحصلش over ولا under, and this affects directly my outcome أو my graft اللي أنا بعملها. لما ال ICU يستعملوا لي inotropes very early ويعاملوا العيان كأنه cardiac patient, even my donor sites for grafts can fail, and I can increase the total body surface area. Physiotherapy طبعا for immobilization, but it also has a direct effect on mortality. If there's an inhalational injury with probably prolonged ventilation, I might need to graft the neck early علشان أعمل early tracheostomy. فزي ما أنا بأثر على الديسيجنز بتاعت التيم، هم بيأثروا على الديسيجنز بتاعتي. طبعا infection and sepsis is a killer in burns, and برضه the role of the surgeon is only source control. But I don't want antibiotics to give or when or what organisms are involved. وبصراحة الرول بتاع الميكروبيولوجي الفترة اللي فاتت especially في الكوفيد يعني steering us in infection control, and we kept on working during COVID. We didn't stop. وthank you دكتورة مشيرة هي معانا النهارده, and she kept us safe during very difficult times. Nutrition برضه is an overlooked area, established طبعا في كل الجايدلاينز، ولكن أهميتها بالنسبة ليا كجراح is directly على my grafting. 20% lean muscle mass loss will affect wound healing, and in the literature it has been published that it affects my grafting specifically. So back to the advances in burn care, وبرضه in the role of the surgeon is a certain point, for me to have proper, to be able to do early excision and proper coverage, I need proper resuscitation with good anesthetists, infection control with a good microbiologist, good physiotherapist to immobilize my grafts, and a nutritional dietitian to optimize my results. طبعا في عدم وجود التيم ده انا مش هعرف اعمل early excision and grafting. And it's been advised if you don't have this team and you don't have a well-prepared center, is to actually leave the burn and excise later. We can't rush and say we're going to do early excision and grafting. فعدم وجود الpreparations والteam ده. We're going to kill the patient. In 2017 وانا مبسوط النهارده كان معانا او لسه معانا الدكتور احمد صبحي. يمكن هو كان من مدير المستشفى وقتها. And it was the development of the new Alaini Burns Center. It was a challenge. We had lots of problems to do with the team and staffing, but we also had a problem with infrastructure والمكان اللي كنا فيه. And we were housed في the 8th floor في مبنى 185. I'm sorry, this is just a quick introduction to our unit. We designed the unit in here to accommodate all the members of the team. وخدنا الانبوت بتاع التيم ممبرز، عايزين الاوضه عامله ازاي، الاي سي يو عايزين بوزيتيف بريشر، نيجاتيف بريشر، فيزيوثيرابي عايزين مساحه ايه، عايزين كوريدورز علشان عينين تتمشى. And this is how we designed our unit with a multidisciplinary in mind. احنا بنعمل او ابتدينا نعمل multidisciplinary team meetings in 2017. We were only 5 and now we're a big team. With different team members. احنا كنا الاول جراحين وفيزيوثيرابيست بس. دلوقتي معانا clinical microbiology, ICU, intensivist, nutrition, and psychology, in addition to our nurses. We do this meeting once a week. It's presented by one of our residents. Ibrahim is not a resident anymore. This is when we actually first started. We presented our case, all the data, member by member starts to say their input on the case. And at the end, we have a plan, a multidisciplinary plan, and we revise this plan day by day. And then for the next meeting, we see what happened and what didn't. فأول كام شهر, we realized our mortality, this is not very accurate, but we realized our mortality was starting to go down. But actually, مش باين هنا بس هيبان في السلايدز التانية, our hospital stay started to go up. We didn't know, the number of days were starting to go up, we didn't know what this meant. But what we realized it meant our patients were living longer. And with the mortality going down 50% in 3 years, ومكملين على نفس percentage, we were discharging more patients with bigger percentage. And we were able, with the team, to admit more patients to ICU. I'm just going to give an example, and this is a case focus session. So we're going to give an example of what we do. معايا هنا سارة وإبراهيم ومنواب. And maybe this is very familiar to you. Actually, you presented this case, and usually we put and shade. Sorry, what shades مش طالع هنا, بس we shade on a lung browser chart which areas. And this is an example of Hamza. Hamza is actually a patient who's just been discharged last month, and he was 1 year 7 months old, schooled, which is commonest type of brain injuries in children in this age group. العيان كان referred إن هو 27%. لقينا هو 44%, mixed depth, mostly deep partial thickness, and he was admitted on the day, فما كانش فيه delay in presentation, and he was admitted directly to ICU. This pictures on admission. طبعا احنا we can't assess properly burns إلا لما بنعمل scrubbing or debridement in the OR. So we do this under a general anesthetic, especially in children, and especially if it involves the face. We use sodium hypochlorite, Dakin solution for cleansing the wounds, and we scrub out all wounds so we properly assess the percentage. فاللي كان بتحول لنا 27% طلع 44%. الدبث بتاعه كان mixed depth, deep partial thickness or deep dermal. It was hot water from a kettle. He arrived around within 8 hours. But still it was quite deep. We did ascarotomies and we did our initial dressing. أهمية الفيرست assessment ده الدكتور وائل صار كان بيتكلم على in most senior surgeons should do the debridement. actually somebody very senior should do this first assessment for the burn wound. علشان نحط البلان what we're going to excise and when ويبقى في sequence. والمفروض برضه الاي سي يو السينيور بيرسون يشوفه في الاول. بعد كده to be honest all the surgeries حد من consultants في انجلترا كان يقول لك burn surgery could be done by any. هو كان بيقول idiot. It doesn't need expertise, it's just excision and grafting. بس when to do it يعني السكيل مش صعبة ولكن when to do it and doing it together with the team that was always the challenge يعني. احنا when we do this we plan for children especially لازم نستعمل definitely non-boundary chart. كان في الميرسي اب كنا بنستعملها to correct لو في اي differences يعني and we assess the depth. We do the escharotomies. In this initial phase كان زمان عندنا الفيرساجيت الهاند بيسز بتاعته مش موجوده دلوقتي بس we published last year لما كانت الهاند بيسز موجوده لما بنعمل ديبرايدمنت بالفيرساجيت ان عندنا more dermal preservation وقعدنا نستعمله for 3 years until يعني recently it hasn't been at the company يعني but we had very good results especially in children. When we talk about dressings, there's no ideal burn dressings by Cochrane review. We just need to achieve a clean, moist environment and to monitor the burn until we are sure whether it's going to heal or if it's going to need debridement. So for dressings, again, sodium hypochlorite, we love using it, and I think our microbiologists would agree, and our infections went down on initial swab. أول ما بنعمل debridement بناخد swab on admission, and we do it with every intraoperative dressing. For this patient and for your deep dermal patient, a deep dermal thickness, we use collagenase. معاه hyaluronic acid product موجود دلوقتي we realized it does work faster especially if we change it once a day. في الأطفال بنحب نستعمل حاجات ممكن نسيبها فترة أطول Aquacel AG plus extra. I have nothing to disclose بس يعني they are it is a very good dressing. وفي الأطفال if we're sure that we don't need to look at the wound again we can leave it for up to 2 weeks. طيب للباتوكس انا بتكلم بس على حاجات سبيسيفيك للاطفال. الاول كنا بنستعمل درمازين ونحطه في البامبرز. ابتدينا نستعمل هايدروجيلز with very good results. والحتت دي especially في الاطفال اللي مش بوتي تريند بتبقى مشكله ان كل ما يعملوا stools it gets contaminated. الهايدروجيل to an extent forms a barrier and most of them heal, not this patient, but most of them heal without any grafting. If we're going to do excision, غالبا المفروض the term is always excision and coverage, excision and grafting, or excision and dermal substitute, but we have to cover by something. If we can't cover على طول, بنقول pun intended يعني it's playing with fire, leaving an open wound, أنا كده فصلت البارrier. We can leave them for 48 hours. We'd use simple things زي البيتادين صوص او الانسات صوص بس ممكن نستعمل برضه الاكواسيل. we're more confident to leave them and recently we started using مش recently قوي we've used negative pressure. اظن دكتور يحيى كنت ناقشتنا في الرساله دي and we mainly use it for cases that were infected. Negative pressure was something that we used on this patient. On day 3 we started our excision. We did excision on the back and left upper limb. We did a split thickness graft to part of it and put negative pressure on the rest. Day 8 اللي هو بنقول we want to excise all burns within 1 week. فخلصنا اتأخرنا يوم وشلنا كل البيرن تيشو اللي محتاج يتشال الا البوتوكس كانت الحاجة الوحيدة. الابر limb was questionable ف ما عملناش grafting في ساعتها. حطينا عليه negative pressure وبيسكلي استعملنا في النيجاتيف بريشر كان او احنا بنستعمله مكان الالوجرافتس. احنا ما عندناش الوجرافتس في مصر ودي عامله لنا ليميتيشن. في البيج بيرنز بيج ميجر بيرنز اللي هنعمل اكسجن 50% او 60% within 1 week او within 10 days مش هعرف اغطيه كله فبره بيستعملوا الالوجرافتس. وفي وجود انفكشن لما بعمل اكسجن اوف ان انفكتد اور ديليد ووند برضه بيتحط الوجرافتس. I don't want to waste my grafts. I want to make sure the bed is suitable and will accept the graft قبل ما اضيعها. فعدم وجود الالوجرافتس we started to use negative pressure مكانه with good results. sometimes في أماكن معينة كان بيعمل شوية desiccation للtissues بس in general and we've published this locally and we're going to do this internationally and it might give us an alternative للallografts. طبعا الديرمال substitutes زي الانتجرا أو البالناك أو كده في وجود infection في الacute phases to be honest we didn't have very good results with them إلا في حاجات معينة اللي هو excision on day one child حتة صغيرة ولكن in big burns بصراحة the results weren't great. حمزة back to حمزة week 2 بصراحة ما أعرفش عنه أي حاجة لأن ال ICU took care of this patient عشان جاله infection. Was it toxic shock or was it just sepsis? There was some debate and these are the actual dates يعني and this was day 7. He started to deteriorate and we had excised everything كان عندنا حاجات على الباك و during this time صراحة ال ICU team هم اللي navigated و this marriage between the surgeons and anesthetists أنا شايف ال cooperation ده needs communication و loss of ego علشان أقدر لما دكتورة حنان تقول لي تعالى أعمل debridement اللي عندي دلوقتي إن أنا أنزل من البيت وأعمله. By time the surgeons do have a feel for these patients, the anesthetists or intensivists, they have a feel for these patients and they actually know قبل ما العيان هيبتدي deteriorate. We come in, we do the debridement and we did this for this patient and this was on day 15 لما كان already ابتدى العلاج بتاعه الدكتورة حنان هتتكلم عليه والدكتورة مشيرة بس on day 15 he started to deteriorate again. We took him to theater in the middle of the night وحتى أنا ما كنتش موجود المدرس كان موجود وقال لنا طب نعمل جرافتنج هنشيل البطق دي الحتة الفاضلة وعملنا الجرافتنج على البطق. I think it was the next day that the patient improved dramatically and started to eat and drink يعني. week 3 and 4 استلمنا العيان تاني وابتدى يبقى في الريهاب فيز كان في أماكن لسه ما عملناش فيها grafting ابتدينا نعمل فيها grafting كان على الباك most of this time. We use donor sites من كذا مكان. We don't like using unusual sites but we have to take from the anterior trunk في العيان ده and our grafts were almost 90% and we say we try to aim to cover the patients within 30 days and we did this in around 35 days but although we were sticking to our goals. This was day 43. We take patients back, pain control and having kids not experience pain is something that we've been doing for the last 2 years. It did affect the cooperation and it affected the quality of coverage, especially if we need to take staples out or كده. Hamza actually came back to the ward امبارح for follow-up عشان كده جمعناه بسرعة علشان عرفنا يبقى عندنا كل الداتا set بتاعته and he was doing well. He stayed for 51 days in total. Our target is around 1 day per percent total body surface area اللي هو المفروض 44 يوم. We're not far off وكان عندنا an episode of sepsis. He's still under our treatment in outpatients for scar management physiotherapy. Would we have done anything differently in this patient? I would just say if we would have done something differently, maybe grafted the upper limbs. معلش أنا عديت في الوقت بس I just wanted to introduce the rest of the team, what they did in this patient. The second week قلنا إن هو ICU mainly. I'd like to invite Dr. Hanan Mustafa, Assistant Professor of Anesthesiology and Critical Care, to tell us what happened with him in ICU.
ممكن دقيقة واحدة يا أستاذ ناصر؟ ممكن دقيقة واحدة؟ ممكن دقيقة؟ اتفضل. أنا بشكرك جدا يا دكتور أحمد على اللي أنت عملته ده كله، بس في نقطة سوداء في علاج حمزة اللي هي التشايلد أبيوز اللي إحنا كلنا لما بنسافر بره بنشوفها وبنعرفها وبنتكلم فيها، إنما لغاية دلوقتي في بلدنا التشايلد أبيوز ده تشايلد أبيوز. المية اللي نزلت عليه وحرقته دي المفروض يبقى فيها شك، وخصوصا دلوقتي في قانون حماية الطفل يجب علينا بمناسبه المؤتمر اللي احنا فيه ده يا جماعه ارجوكم ان انتوا تبصوا الموضوع التشايلد ابيوز ده وتاخدوه بطريقه طريقه حكيمه شويه. السؤال الثاني، بتاخدوا فلوس من العيانين ولا لا؟ شكرا.
وبالنسبه للتشايلد ابيوز واهله طبعا الكلام ده لازم يبقى سسبكتد، واحنا بنعملها بثلاث طرق. ان بناخد الهيستوري في الاطفال من كذا حد، ان هو لازم يبقى كونسيستنت. اي ديلي ان برزنتيشن لو جه بعد يوم وما كانش راح مستشفى برضه بنشك. قليل ما بنبلغ، بس we do take non-accidental injury into mind. And يمكن الدكتوره حنان will talk about the relatives a little bit more عشان they were involved in this case very much.
شكرا.
Surgeons, burn surgeons and experts. I see a lot of familiar faces from my professors and colleagues. I hope it's going to be a beneficial presentation. Hamza, and actually pediatric burns have been a soft spot in my heart. Everyone who worked with me for years when I was an assistant lecturer know how much I'm deeply in love. Actually, I spent a lot of my time, around 10 years, going around the world trying to know how to help them. For me, as an anesthesia consultant and an intensive care, having a pediatric burn in my ward was always a challenge because we're not pediatricians, and I believe in subspecialties. But all around the world, pediatric intensivists are treating pediatric burns are usually like myself, so it took a lot of work, and I hope that paid off. I would like to thank also the burn ICU team. It's not fair to be here talking in front of all of you. They did a great work. Actually, they even worked more than I did. I hope all of you would. I will try to be short. Alhamdulillah, here. Okay. I would like to thank my team, the ICU burn unit team. They work so hard. They give hope when not a lot of people give hope to patients, and they've been there for like 14 years, even before we took the unit in the 8th floor. And I would like definitely to thank Dr. Nawar, Professor Tina, Professor Shira, Professor Nancy for being here and having me among the MDT presentation. I would like also to thank Hamza. Hamza did a great work. He's just 1 year and 8 months old. And I would like to surprisingly thank his mom and his aunt because they've been so dedicated. And from my experience with pediatric burns, if we have a dedicated mom, I think it's like more than 50% of the effort. They make a great difference. We never know from my يعني والله أنا حاسة بحضرتك جدا، بس جايز الواحد لما كان قبل كده ما عندوش أطفال غير لما بقى عنده أطفال. Sometimes mistakes happen. أنا عارفة إن دي حاجة it's so great، بس I've seen a lot of cases بتبقى غصب عنهم. Sometimes they don't live in a normal place to live in. They don't have heaters. يعني انا مش
فوزي بعد لسه بس اتاخرنا قوي، فعايزين نلتزم بالجزء الميديكال عشان كان في امبارح محاضره كامله على الجزء ده في النادي.
والله
ماشي نلتزم عشان الوقت بس.
انا مع حضرتك بعد المحاضره برضه هتحب تاكد. First احنا what we do in the ICU or having the patient that resuscitation. Actually I'm talking about Hamza who's a pediatric. Pediatrics, I always say they are not tiny adults. We should not, as intensivists, treat pediatrics as tiny adults. We have to customize a plan for them. Some things are a bit common and others are totally different. So in resuscitation, after the primary survey, we have to take care very much for the airway, breathing, circulation, disability, and the exposure. In the case of Hamza, alhamdulillah, he didn't have any airway involvement. It was just cold, so airway was okay, and we started with the circulatory resuscitation. He had a more than 10% total body surface area burn, so we started with first aid, analgesia, cleaning, assessing, dressing, and intubating with the surgeons on the team. What is our preferred thing to resuscitate the patient with? Still, it is the lactated ringer. Physiological solutions still have the upper hand. Some people debate it, some people debate colloids, debate plasma, debate albumin. It will come when we need it involved. But as resuscitation fluid, we still prefer the Parkland solution or the lactated ringer for resuscitation. We use the Parkland formula or the more conservative Brooks formula for adults, and we have it still there for pediatrics according to the case. The Parkland formula has the 4 ml per kg per total body surface area, and the Brooks is more conservative, and we still debate among the team which to take the upper hand, the normal modified Parkland or the Brooks. We have to bear in mind when we dealt with Hamza that any pediatric burn with greater than 10% total body surface area requires an IV fluid replacement, which he needed, and that in children a bolus of 20 ml per kg should be started with. We have to bear in mind that since we have a more than 25% burn, that systemic edema is a threat, starting from 4 hours after the burn, that we a lot of times don't see the patient. In Hamza's case, we did not, till 36 hours after. As I mentioned, that the crystalloid versus colloid debate is still a subject of a lot of interest, and that crystalloids are still the primary choice, even in the maintenance fluid for children specifically. We have to bear in mind that children are more liable for hypoglycemia, so adding glucose is always a threat that we have. In the primary days, we measure the glucose very tightly around every 2 hours, and when things are more stable, we can space it to 4 hours, and when it's more stable, we space it further with no problem. I just wanted to hint for the things that I think as an intensivist and anesthesiologist that could affect the outcome of the surgeon and could be a whole troublesome, and that a lot of my colleagues can fall into. Something called the fluid creep. When we resuscitate the patient, we always think that we are saving him, we are saving his life, but actually too much saving is harmful, and that, especially in pediatrics, is called the fluid creep, which is, as I mentioned, under resuscitation, can lead to complication, and over could be detrimental too, and that it can lead to ARDS, multiple organs dysfunctional, abdominal and limb compartment syndrome, and cerebral edema. Fluid creep may occur if volumes of drugs as antibiotics, electrolyte replacements such as magnesium are not taken into consideration, and often such medications are given diluted in volumes that are not insignificant, especially in children. Furthermore, by chasing an unrealistic or excessive urinary output without considering the full clinical picture, the risk of over-resuscitation will increase. And that was a challenge in Hamza. When to add albumin? I think this is a long-time debate between surgeons and intensivists for all, since I've started the practice till now, but there's a protocol that we always try to maintain in burn patients, the patient well hydrated, and we look to the lactate and to the urinary output and to the acid-base status of the patient as a benchmark that we measure where we're going. A urinary output less than 0.5 ml per kg for adults and from 1 to 2 ml per kg for children for more than 3 hours may indicate that the patient needs to step ahead and go into a colloid as albumin. What we give is albumin 5% with a dose of 0.5 to 1 ml per kg per total body surface area divided over 24 hours. When to stop resuscitation? When the patient is normothermic, and this in pediatrics should be in a very large frame. We cool the burn place. We don't cool the patient. Hypothermia in pediatrics could be fatal. Age-appropriate hemodynamics and sustained urinary output and minimal systemic acidosis. Another challenge in Hamza's case was the burn pain. We use for the background pain, we can use paracetamol, we can use non-steroidal anti-inflammatory drugs, but they have to be in caution because they have a lot of detrimental effects if they are used liberally, and sometimes they are what we have. Okay, and opioids as morphia. In procedural pains, we can use ketamine propofol, ketamine and fentanyl, and dextromethorphan if it's available. And for chronic pain, we can use gapins or morphia, and morphia is usually used. We have another challenge is the intra-procedural blood loss, and I have to hint that it is really grave, as that 3 to 5% estimated blood loss may occur for every 1% of total body surface area burned excise, and that blood requirements for a given procedure may be estimated during following formula, which is 3 per weight per percent burn, and that surgical techniques could be done. And here comes the benefit of having a very in harmony multidisciplinary team that they can use surgical techniques to reduce blood loss, as adrenal swab and the subcutaneous injection of adrenal pre-excision. The other and the most grave problem, the threat and the atomic bomb that can happen in a patient is sepsis. And in pediatrics, sepsis is more and more a threat than others. Unfortunately, the definition of sepsis for pediatrics is not as updated as others, but on a consensus, sepsis means organ dysfunction. We have an infection, and this infection has an organism that comes and induces a grave atomic bomb inside the patient, causing a lot of organ dysfunction that could affect the brain, and the patient has an altered consciousness, the lung, which is hypoxia, the kidneys, oliguria, and increased creatinine, and heart hypotension, where we start adding the patient on inotropes, and this would be not a very happy event for a surgeon putting grafts. According to the American Burn Association, when we're having 3 of the following, temperature more than 39 or less than 36.5, progressive tachycardia, according to the age, and progressive tachypnea, thrombocytopenia, hyperglycemia, and inability to control entrance, or one of the following, having a positive culture, that we will have more and more detailed explanation with Dr. Mushira, pathologic tissue source identified, and clinical response to antimicrobial agents. What to do? Source control, and not only to be attacking the surgeons come into source control, I have to search for my intravascular devices and other sources of infection inside the patient that could be mine, not only yours. And the timing of the deployment, it's according to a communication between the surgical team and the intensivists. We have this other atomic bomb, which is another variant of the septic shocks, the toxic shock syndrome, which is a multi-system disease manifested by sudden onset of fever, chills, hypotension, and rash. Multi-system involved may cause vomiting, diarrhea, myalgia, mucose membrane hyperemia, mental confusion, and actually Hamza was suspected to have a toxic shock syndrome, and he received 3 doses of IVIG, which responded beautifully after the 3rd dose and after the debridement and the grafting, as Professor Nawar mentioned. Okay, and I will leave the rest of the details of the sepsis state and the infection state and the antibiotics to Dr. Mushira. I just would like to flash for the pediatric burn management that we have to cool the burn and not the patient, especially in pediatrics. We have to be very cautious that when we cool the burn, the patient not go into hypothermia, which could be fatal, as I mentioned, and that fluid creep is a hole in your boat. If you think that you are saving the patient and he has a fluid creep and you over-infuse him, you have a hole that you have to stick something in it before going along, and that burns injury leads to patients having a hypermetabolic and inflammatory response after the first 24 hours, and that's what made us in our unit usually add beta blockers To this date, and Dr. Dina, our professor, nutrition professor, will talk on it later. It's not. Thank you. I would like to invite you to know more and more details about the antimicrobial status, the sepsis, with Dr. Mushira. Dr. Mushira is the lecturer of clinical pathology and clinical microbiology and is a lifesaver for our team. Please, Dr. Mushira.
Thank you so much, Dr. Sandra. Thank you so much طبعا Dr. وائل الشاعر على invitation ودكتور أحمد نوار. Thank you so much Dr. أحمد نوار. يعني is the beating heart of the burn unit الحقيقة. I cannot acknowledge enough his work إنه يخلي burn unit. يعني I've been lucky to be part of the team for a few years. والحقيقة ما فيش مكان فيه dedication ويعني to improve and continuously make a very sustainable with very beautiful outcomes الحقيقة. Thank you so much Dr. Ahmed Nawar, and thank you so much for including me. Thank you so much for the rest of the team. To start with Hamza, زي ما انتم شايفين he's a very beautiful and cute kid. Gave 44 or 45% cold burn. For the sepsis events that we had, first we started him on empirical antibiotics according to our internal policy. We have our internal policy for antibiotics guided with our own antibiogram. It's updated annually according to the resistance pattern that we recovered. He was feverish, his TLC rose to 19.4, hemoglobin was 10, platelet count reduced from 380 to 190, CRP was 270, pan cultures were taken. ومهم قوي ان انا highlight ان pan cultures بالذات لو patient feverish, blood culture it has to be taken at the spike of fever. دايما بنقول للنواب لما العيان يبقى feverish اسحب في وقت السبايك قبل ما تدي اي antibiotic dose blood culture to give a better result and higher yield of microbes. The wound culture بتاعته was positive for Acinetobacter MDR. Unfortunately, the culture he was upgraded culture guided to colistin, ampicillin, sulbactam, and daptomycin. Yet, unfortunately, the fever continued. Fluconazole was added empirically. The patient had his first graft in the buttocks, yet he still had a huge raw area, so we had a problem and source control. The fever spiked to 40, CRP rose again to 290, lethargy, tachypneic, tachycardic, and elevated lactate, and he became acidotic. So it was a debate if he was at that time in a toxic shock syndrome. So the decision was made to give him IVIG. He improved dramatically after 2 doses. He became stable, grafts were continued again. Yet, unfortunately, 1 week later, his markers started going up again, and pan cultures were taken. مهم قوي ان احنا نبقى guided دايما ب repeated cultures مش culture واحده وخلاص ونكمل empirically. The blood culture and urine culture were positive for Candida. Caspofungin was started. Tissue culture was positive for Providentia. وده كان للاسف كان وقت outbreak في ICU Providentia. We started him on ceftazidime avibactam. Grafts were continued, and he was stable to go and ready to go home. He was and received another dose of the IVIG as well. He improved. The grafts were continued at the same time. He was de-escalated to oral fluconazole for 4 days, then stopped with negative blood culture follow-up. The importance of the infection in burn, it comes from that it's the leading cause of morbidity and mortality. 51% of the patients' mortality in burns attributed to infections. The most common are the pneumonia, the burn wound infection, UTI, also amid the antimicrobial resistance that we encounter, especially in Egypt. Estimated 180,000 deaths every year are caused by burns, especially in middle-income countries. Most deaths of burns are due to sepsis or complications due to inhalation and injury. طبعا أهم مشكلة عندنا هي absence of the physical barrier, the skin, that leads to invasion of the tissue layers and leads later on to the sepsis and multiple organ dysfunction. Patient كمان مع حجزه في المستشفى والhospital acquired infection rates rise مع catheter related infections زي ما دكتور حنان highlighted ان احنا مش بس البيرن سورس لا كمان هو الكاثيتر سورس لو patient بانهيليشن injury بيتحط على ventilator فالفاب also is a possibility. The source of infection or the microbe most probably بتبقى from the patient's endogenous flora, but still we have the exogenous flora, the exogenous sources from the environment or the hospital or the community, the healthcare personnel as well. Also exogenous environments from the hospital environment, and unfortunately we have multiple superbugs in our hospitals in Egypt as a whole, and of course in Alaini. We have resistant bugs, the superbugs that we usually encounter, the MRSA, the VRE, the Pseudomonas, and the Acinetobacter, and the Carbapenem resistant Enterobacters, unfortunately. It's really important to distinguish between colonization and the infection. There is a huge difference between both, but still they are very close to each other. Colonization, it's not a true infection, it's only microbial cohabitation within the host tissue without significant disruption to the host tissue. While the infection is microbial invasion of the host tissue with subsequent injury as a result of the microbe and the host-specific response. مهم قوي ان احنا نفرق بين colonization والinfection. ليه؟ عشان لو انا عندي infection I have to treat it. If I have a colonization and if I treated it, I'm misusing the antibiotics, and this leads to more and more resistance. It's really important. Infection is your diagnosis, it's not the labs. دايما في عيانين البيرنز الجراح بيبقى اسهل حاجه ان احنا ناخد the very superficial wound, and it comes back of course with microbes, and it's going to be polymicrobial, usually mixed colonizers and stuff. So it's important that to realize the diagnosis of the burn wound infection, it's the clinical, not only guided by the lab. The organisms do not covered from the wound, do not define the infection, and also colonization precedes the infection. So if I have a colonizers, I'm guided. لو العيان ابتدى يديني signs of infection, colonizers والswabs اللي احنا بناخدها دي بتبقى guidance لينا بعد كده. أهم حاجة to control the vicious circle and to cut the vicious circle is prevention of infection in wound care. Aseptic technique is a great priority. وقد ايه بنشوف outbreaks من أقل حاجة لو حصل breaking للأسeptic technique. Standard infection prevention procedures including hand hygiene, environmental disinfection. ودايما كنا بنurge النواب انه لازم ندي وقت بين العيان والعيان في العمليات انه يبقى فيه proper disinfection للenvironment قبل ما العملية. لازم abide by the infection prevention rules وقت الwound debridement. Recognizing sepsis in burn patients is very challenging because many of the symptoms are present already in burn patients who don't have any infection. So it's really important to clinically diagnose it, not only depend on the lab. For the detection of the organism and the sampling, أحسن sample بالنسبة لنا and the best quality sample and the gold standard is the tissue biopsy, not the swab. The swab gets the whole colonizers جاية من على السكين واقعة جوه raw area. فلما هجيب السواب هجيب ال very superficial colonizers, not a true pathogen, and it's going to misguide you and you're going to use the wrong antibiotics and lead to more and more resistance. فدايما بنقول انه ايه tissue biopsy weekly لازم يتاخد tissue biopsy مع العيان واحنا بنعمل له debridement. السواب is يعني is go for it if you don't have other option. ونجو وقتها for deep swabbing after washing the raw area. Also detecting anti-R organisms causing the BAP with bronchoscopy لأن احنا مع عيان على ventilator فترة طويلة هلاقي عندي respiratory colonizers. فاit's better برضه إني أجو deep وأجيب بالcolonoscopy and also the blood culture for the suspected sepsis. The more common organisms in the first 48 hours are the gram-positive organisms, the skin colonizers, the coagulase negative staph, the Staph aureus. As we go further and as after 1 week, the gram negatives they start to take over. نلاقي سودوموناس ايروجينوزا، نلاقي انتروباكترالز، ممكن نلاقي CREs كمان. ودول لو لقيناهم colonizers they will prophylaxis or given. احنا عندنا ماشيين ان احنا بندي pre-operative prophylaxis قبل العمليه وبعد كده guided according to our antimicrobial policy. This photo highlights قد ايه ان احنا لو بندي if you're giving the bug or the microbe the wrong antibiotic you're converting it into a super bug and a multi-drug resistant bug. So please be aware before giving the antibiotic that you are contributing, if you're giving the wrong antibiotic, contributing to the antimicrobial resistance. Toxic shock syndrome, Dr. Hanin highlighted it, but I want to highlight its life-threatening complication. مهم جدا ان احنا suspect because it happens early post-burn and we can do the prophylaxis for it. This is our local antimicrobial policy for burn unit. So if the patient is infected or suspected of infection, we have to go for the empirical therapy and cultures, do the cultures. If not, don't give antibiotics and don't go for the antibiotics. Just stick with the local management that you have for the wound. Start empirical antibiotic if the patient is suspected with sepsis and infection. We start with piperacillin, tazobactam, or we can upgrade to imipenem plus or minus amikacin. It's an SOS for patients on sepsis, and plus or minus vancomycin. If the patient does not improve and we still have negative cultures, then we could add caspofungin because the candida is a possible source of infection, especially with the continuous use of the antibiotics for patients with prolonged hospital stay. Finally, the antimicrobial stewardship in burns is really important. It's very important to choose the right antibiotic for the right patient with the right dose and the right time and the right route for the right duration. So the antimicrobial stewardship, it's like coordinated interventions to aim to reduce the antimicrobial resistance and improve and measure the appropriate use of the antibiotics. It can help improving the prescribing practices and identify resistance patterns. A local antimicrobial stewardship بتاعتنا it's a multidisciplinary approach. وزي ما قلنا احنا بنجدد الانتيميكروبيال policy annually according to the antibiogram بتاعنا. بنطلع resistance patterns ونشوف continuous practices. لو في عندنا repeated reported outbreaks, what to be done to improve and reduce the resistance. For our take-home message, it's really important to abide by the strict infection prevention measures, constant wound surveillance, and regular sampling of tissues, not swabs for quantitative culture. Early excision of wound and wound closure remain the principal adjuncts to the source control of invasive infections in burn patients. It's really important to control the source because if you don't control the source, the patient will, the bacteria will come back no matter how much antibiotics the patient will receive. Hospital antimicrobial stewardship is really important in improving the appropriate use of antibiotics, and thank you very much.
How often do you see or do you meet fungal infection في الwound مش candida
الفانجل انفكشن في الوونز طبعا هي زمان ما كانتش كتير كده، بس ابتدت تزيد قوي الفتره الاخيره مع الكونتينيوس يوز اوف انتيبيوتكس، واحنا عندنا الريزيستنس للاسف في مصر ابتدى يزيد. ابتدينا نشوف حاجات XDR اورجانيزمز اخر السنه، فابتدى يزيد معاها الكانديدا في الوند انفكشنز. يعني I think if a given average not less than 15%
شكل معين شفنا حاجه سرقه
كان يعني mainly candida species.
شفنا شكلها كلينيكال. احنا شفنا كذا عيان فجاه كده في الاطفال ليه فجاه سواد كل الجلد سواد كل اسود ولا نشكل سبب. هذا ستريبت هوميتيكس مش اكسانا جاجينوزا. هل دوت فانجل انفكشن وما قدرناش نوصل لحاجه. ايه السبب فجاه يعني السواد دايما ده بيولد وغالبا يومين ثلاثه وبيتحسن.
هو مشكلة ان هو يدخل في كانديديميا كمان، هي ده الهاي ريسك. فلو if a patient already on prolonged antibiotic use and if it's not improving, it's recommended to add the antifungal whatsoever and sample من الwound وsample من البلود زي حمزة the candida was recovered from the urine and the blood, and most probably the source was the urine, or it could be endogenous.
انا بتكلم عن شكلها، هل الشكل الاسود ده اللي بتشوفوه في البيكتشر بالظبط ما حصلش فيها حاجه، حصلت في كذا عينه ورا بعض وبعدين تختفي وتظهر تاني، مش لاقي لها سبب لحد دلوقتي. طيب نسيت الحاجه الثانيه كنت بتقولي حاجه كده دلوقتي. بالنسبه للاطفال الاميكاسين، هل بتدوا فود دوز؟ لان احنا خدنا زمان ان هو مؤذي وبيعمل نيفروتوكسيستي وي بس ستيل السيزون بيحبوه جدا في الاطفال، ولازم ستريت 10 ايام.
هما مش بيحبوه قوي، ويعني بيبقى دايما ديبيت بيننا وبين الاي سي يو شويه. يعني احنا از مايكروبيولوجيست وي بريفير ذا اميكاسين ان هو بيقلل اللود من على اذر انتيبيوتكس زي الكولاستين اللي ابتدينا نشوف الريزيستنس بتاعه. فالاميكاسين حتى ايفن بره انا شفته في انجلترا وفي امريكا it's used as an SOS if the patient is on sepsis and he's not improving it's recommended.
لو في ريزيستنس ان هو هتدي ده البيزك اول ما في انفكشن ولا نيجاتيف تدي اميكاسين؟
لا
حاجه هتاذي الكدني في طفل اوريدي ممكن يبقى
لا زي ما قلنا هو it's an SOS. لو عندي emergency patient is not improving on the dynamic it could be up to 7 days.
مش 10 days or 14 days.
لا خالص. It could be up to 7 days. وإيفن I have seen إن هو ممكن بيدوه بره even single dose 24 hours or 48 hours if the patient is not improving he can de-escalate مستريح.
أول ما بيدخل يعني في ستاندرد بروتوكول بياخده؟
لا احنا ما بنديش ستاندرد بروتوكول البيشنت if the patient is infected then
لو داخل عادي
لا خالص. والعيانين اللي في الوردز we don't والعيانين اللي في الوردز we don't start with antibiotics and it's no difference. يعني مش بيزود الريتس، بالعكس احنا بنستخدم بس البيري اوبريتيف prophylaxis that we have.
دكتور ماجد
معلش هسأل سؤال واحد. How often do you get requests for quantitative culture?
Whether burns or wound, and what kind of quantitative wound culture do you do? The formal colony counting or the rapid slide technique?
We don't have the rapid slide technique, unfortunately. We have the conventional colony counting.
Okay.
We don't see it.
You don't get it?
No.
This is what I want to emphasize, that the deciding factor in our deciding parameter for diagnosing wound infection is wound quantitative wound culture, and it has been established that colony bacterial wound count exceeding the 10^5. This is we don't ask them to do it. We don't know how important it is. We have to know the importance of doing a quantitative wound culture. I don't really care about the type of organism. This I will do it with a swab. But any swab you will do it for any open wound, you will find the organism. But how many organisms? What's the count of the organism? This is what decides wound infection, not the clinical signs. So you don't get it. We don't ask you about this.
No, we don't.
It's our fault.
دي نقطة مهمة ناخدها فعلا أي حاجة سايز ناخد منها سؤال. هل عملتوا فرق ما خدتوا التيشو كلشر نفسها وخدتوا سواب لقيت في فرق بينهم؟
طبعا فرق كبير جدا. السوابس دايما حضرتك هتلاقي كتير قوي بالذات في المستشفيات ان الريزلت ميكسد كولونايزرز. and if you recognize the mixed colonizers you know يمكن النواب اكيد هيبقوا عارفين. لكن if you get a tissue swab and a proper tissue culture you have the pathogen.
بدل الدكتور ماجد حضرتك قلت ايه يعني هعرف الاورجانيزم الاسباب، لا ده كده مختلف برضه، الكالتشر هيطلع لك اورجانيزم مختلف برضه مش جاست الاسباب، دي نقطه مهمه جدا.
كوانتيتيف
مهمين طبعا. دكتور يحيى عشان بس الدور.
انا طبعا موافق حضرتك ان مفيش بروتوكول او ان انا اديه كوفراكتيك انتيبيوتكس كده عيان داخل الدور اديله كوفراكتيك انتيبيوتكس. لكن انا بعمل ايرلي اكسجن، يعني هعمل اكسجن اهو في التيشو، هل في بروتوكول بتمشي عليه؟
بندي بري اوبريتيف prophylaxis for pre-operative surgical one dose single dose 60 minutes before the operation.
ما تبقاش شديد خالص.
اوكي.
دكتور صفوت
هو الحقيقة في البداية I enjoyed every minute in this session. أنا بشكرك يا أحمد جدا، بشكر كل واحد فيكم. هو أغلب الحاجات اتغطت، بس أنا عايز أوفر emphasize the personal experience over years إن الفانجل infection is a serious thing. وهو زي ما اتعلمنا ما احنا صغيرين والأمور ما اتغيرتش كتير، إنه السترينز اللي يبتلى بيها البالفون سيبسيس في الايرلي 1 week او 5 days مختلفة عن السكند 5 days، والفانجل we should anticipate it بعد اسبوعين. even because of concerning fungal infection, not only burns, conforming مع burns. لو patient is a candidate to be kept in ICU أو had more than 2 antibiotics for a certain amount of time. فالfungal infection is very important, but it's not that early. هو أنا aware of the MRCA and the Zirna and the بلوى كبيرة زي الزنونس، بس إيه
Providentia is a gram-negative bacteria, gram-negative bacilli, and unfortunately ومش ناس كتير بتبقى عارفة المعلومة دي إن هي resistant للكولاستين. فوقت ما حصل الاوت بريك بتاع البروفيدنشيا كانت it's very challenging. العيانة
gram-negative بكتيريا.
gram-negative بكتيريا.
يعني دي
identified from the lab. انا ما جبتش النهارده حاجات اللاب
عشان ما نضيعش وقت. I enjoyed جدا السلايد اللي انت قلت حضرتك فيها ان السيستميك سيبسيس او السيريس سيبسيس او الامبورتنت سيبسيس البيرمنت ما بيعتمدش على
لا بس لازم
it needs a clinical judgment when a treating physician. وختاما احنا دلوقتي لو العيان ما عندوش overt systemic sepsis ما هوش متداول او محتاج a strong stand. I cannot agree more عن اللي قاله الأخ العزيز على البكتيريا count in tissue biopsies. Swabs is nothing. Swabs is nothing. فرأيي أنا
دي حقيقة. هو بره كانوا بيقولوا لي swabs
بس عايز أقول البيرمود infection البيرمود biopsies whether quantitative or qualitative هي ولا البلاد كلشر اللي هتخليك تختاري which type of antibiotic. وخلاص مش هسألك حاجة.
both if the tissue biopsy with a true infection لازم مهم ان انا اكوريليت كلينيكال.
مين اقدر البلاد كلشر ولا حاجة تانية؟
لا بلاد كلشر طبعا it's the top لان it means sepsis ان البيشنت عنده بكتيريا في البلاد.
وعشان الوقت بس في نص دقيقة للدكتور علي وربع دقيقة للدكتور أحمد وهنقفل بس. لا انت ربع الدكتور علي بس الأول نص دقيقة.
السوابز اهم السواب يديشوا
طيب احنا يا ريت بس نقول ما نكررش الكلام اللي اتقال يا جماعه عشان
اهم حاجه الثروت سواب ساعد دخول العيان لنفرين the burn patient and the nursing personnel. The burn patient ده الانديكيشن الاولاني if you need a prophylactic antibiotic, especially penicillins, in the very early period. The throat swab is the deciding factor. As you know, the streptococcal lives in the throat and as routinely abroad. And here we used to do the throat swabs.
شكرا دكتور علي. دكتور احمد. دكتور احمد ربع دقيقة.
مش بنعمل طبعا unfortunately screening for most of the patients يعني بس we screen with a tissue biopsy weekly.
I advise you to have this throat swab as a routine once the patient is admitted.
رسالة وصلت بس معلش عشان احنا علينا ضغط جدا من الوقت. ربع دقيقة سؤال سريع جدا معلش بعد اذنك.
الواقع الخبرة بتاعت الجراحين والسبيست clinical signs بتاعت الانفكشن غالبا بتكون سكوب يعني بتاخد جراحة والبيشنت بيبتدي بقى على ثالث او رابع يوم بيبتدي مش كولونايزيشن بيبتدي في signs. Even the only first signs you can say that I want to start with antibiotic. انت بتتفقوا على كده يعني الحته دي ما عندهمش كده. لو اتاخد بدري يخش في ريزيستنس، لو اتاخد ليت البيشنت ويل بي
هو بتبقى كذا حاجه مع بعض. بس هو احنا بنبدا بيبقى فيه فيفر سبايكينج فيفر مع ليثارجي فيفر وليثارجيك والاكتيفيتي طبعا.
احيانا ممكن كومبرايز مش فيفرش خالص. فيرست ساين في الكلينيكال ساين ده عنده بس تاكيكارديا او
ليكوسيتيك
واحيانا ما يكونش الفيتال ساينز كلها بتقول ان هو مش انفكتد.
هي زي ما قلنا هي دي امور طبعا كلينيكال دايجنوستس، يعني دكتور حنان تفيد عني في الجزء ده. اتس ريلي امبورتنت تو هاف ذا كلينيكال دايجنوستس. احنا بالنسبه لنا از مايكروبيولوجي انا مهم عندي ان انا الكلينيكال ساينس بتاعتنا بتاعت البيرن اسوشيشن مع اللابس بتاعتنا لقينا السي ار بي عالي تي ال سي عالي مع الكلينيكال ساينس خلاص this is a patient to be diagnosed assessed and be managed. I would like to present Dr. Dina Sulaiman, Assistant Professor of Anesthesia and ICU Clinical Nutrition Consultant معانا في التيم، وكانت إضافة الحقيقة مهمة جدا.
دكتور أحمد نوار يتكلموا يلغوا البان ده مش لازم عاملينها مع بعض يعني. اتفضل حمزة برضه ولا حد تاني؟ عندكم عيين تانيين؟ هو اللي في الوحدة كلها حمزة بس.
مساء الخير. مساء الخير جميعا. أنا بشكر الأورجنايزنج كوميتي بتوع الإشاعة ماي جريتنجز للتشير بيرسونز، وبشكر الدكتور أحمد نوار الحقيقة على إن هو يعني ليدر أوف أور تيم الحقيقة، وبشكر زملائي في التيم، وبشكر الحقيقة لازم أذكر الدكتورة سحر الشاي الحقيقة هي ماي كوليج في النيوتريشنال اور نيوتريشنال تيم في الاي سي يو. هتكلم على المالتي ديسيبلينري ابروتش ريجاردنج النيوتريشن. انا بس حبيت السؤال اللي هو بتاع السؤال بتاع حضرتك. هو احنا بنلاحظ الحقيقه ان العيانين دول اول حاجه ان هم بيبقوا ليثرجيك جدا من الفيرست ايرلي ساينز الليثرجي، هم يبطلوا يلعبوا لو طفل صغير يبطل ياكل يعني حتى without fever. دي بتبقى alarming sign إلى حد كبير. نعم؟ دايما كده ديبيت يعني ديبيت ويلدي بس بس هو احنا دي بتبقى alarming sign لينا وبنبقى فوكسنج بنتابع العيان كويس. نعم يا فندم؟ يس انا بتكلم على كلينيكال لان الدكتور كان سؤاله كلينيكال.
معلش الوقت يا جماعه نلتزم بالوقت، معلش مفيش اسئله في الفضول لو سمحتوا، معلش ده قرار
تمام. كريتيكال تشيلدرن.
يلا يا دينا
اوكي. النيوتريشنال مانجمنت اوف بيرن بيشنتس الحقيقه as دكتور نوار said early nutritional management is very important لانه احنا المسل loss في our patients very critical. يعني starting from 10% هيبتدي يحصل immunological derangement، 20% هيبتدي يحصل مشكله في الهيلينج، up to انه لو وصل ل 40% هيبقى leading to mortality. لو بما اننا اتكلمنا على our patient حمزه فهنبتدي نتكلم عن children الاول. والكريتيكال ايل children الحقيقه at higher risk than adults of developing nutritional deficiencies and altered nutritional status. Compared to adults, children have lower percentage of muscle and fat mass, higher resting energy requirements, cannot endure fasting as long as adults, and survival is limited by protein depletion. So in critically ill children and particularly in burn children, the nutritional status will deteriorate very rapidly. That's why intervention should start very early. دلوقتي recommendations بتاعت السوسايتيز الأوروبيان سوسايتي of intra-parental nutrition recommending إن احنا نبتدي nutritional interventions within first 12 hours of burn. الأمريكان سوسايتي الحقيقة بقى كمان emphasized إن احنا we can start as soon as 4 to 6 hours even من البرن. الانرجي ريكويرمنتس الحقيقه في الادلتس وفي الشيلدرن يعني something very important ان احنا نحسبها. والجولد ستاندرد بتاعنا هو الاندايركت كالوريمتري طبعا لو كان افيلبل، لانه هو ميزه الاندايركت كالوريمتري الحقيقه انه الانرجي ريكويرمنتس اوف بيرن بيشنتس از markedly changing over time. يعني هو it's not fixed زي يعني او stabilized زي other critically ill patients. It's very changeable. And that's why
واي لو عندنا اندايركت كالوريمتري هيبقى فيري بينيفيشال. احنا الحقيقه بما انه اتس نوت افيلبل فاحنا بنعتمد على في الاطفال على الايكويشنز. في البيدياتريك بنحسب بنشوف الايكويشن، واحنا بالنسبه لحمزه حسبنا according which goes according to age and 6 حسبنا له الريستنج انرجي اكسبنديتشر وبشوف الايكويشن. والحقيقه احنا دايما بنبتدي فيري جراديوال، وفي الايرلي فيز دايما بنبتدي بالريستنج انرجي اكسبنديتشر او ايفن جزء من الريستنج انرجي اكسبنديتشر، وبن ابجريد جراديولي علشان يبقى في endogenous production of substrates from the body. We don't store it with the full requirements. As regard the proteins, the protein requirements بتبقى higher طبعا than other critically ill patients. في الادلتس بتبقى 1.5 to 2 grams per kg per day compared to 1.3 في other critically ill patients. في children بتبقى 1.5 to 3 gram per kg per day. And nitrogen balance هنا حساباته بتبقى it's not that easy due to الاكسوديشن اللي بيحصل من الهرمونز. النيوتريشنال بروتس الحقيقه احنا من اول البيشنت ما بيدخل بنعمل له نيوتريشنال اسسمنت وبنكالكوليت البروتين انرجي كوانتيتي زي ما قلت لحضراتكم ايضا بالشيفت ايكويشن او بالاذر ايكويشنز اللي هنتكلم عليها في الاذرز دلوقتي. ونستارت with 25% of the resting energy expenditure actually، لانه في الاكيوت فيز زي ما قلنا الفيرست 48 hours بيبقى فيه an endogenous production of energy. بعد كده بنكونسيدر other alternatives لو كان في مشكله في الانترال فيدنج. لو ما عندناش مشكله we usually use the gastric route if we يعني we start with the gastric route. If failed we might proceed to either post-pyloric feeding أو إلى parenteral nutrition. Supplementary parenteral nutrition can be used in these patients وبنستعملهم to meet the energy requirements that might not be used reached بالenteral feeding. و specifically هنا في البيرن patients يبقى في repeated surgical sessions و repeated fasting. فالريبيتد فاستنج لقوا ان هو لما عملوا ستاديز بيقلل الانرجي انتيك باي approximately 50% on the total. وعشان كده قالوا ان احنا ممكن we have to either do one of things، حاجه اسمها catch up، ان احنا ممكن نزود في الفتره اللي البيشنت مش فاصل فيها نزود الريت اوف انرجي انتيك، او ان احنا ندي supplementary parenteral nutrition في بعض البيشنتس. الحقيقه احنا عملنا كده في حمزه لانه حمزه كان في فتره هو كان بياخد اورال انتيك كويس سربرايزنجلي رغم ان هو كان البيرن اريا بتاعته كبيره، وكنا بنديله اورال سبلمنت مع الاورال انتيك. ولكن في فتره اللي حصل فيها السبسس ابتدى الاورال انتيك يقل وابتدى يبقى دراوزي، فخدنا ديسيجن ان احنا نحط له ان جي تي. الحقيقه هو دخل قبلها عمل الديبرايدمنت وخد الاي في اي جي، والحقيقه سربرايزنجلي بعد 6 اورز اتحسن وابتدى ياخد اورال فيدنج كويس تاني. وكان الحقيقه يعني كان في ريجكشن كده من المذر اللي بنحط ان جي تي، فاحنا ويتد 6 اورز لقينا ان هو ابتدى رجع تاني للدومين بتاعه وابتدى ياخد اورال فيدنج. ذاتس واي احنا ادينا له سبلمنتري بارنترال نيوتريشن. البيشنتس ويز نيزل بيرن كمان عندهم انكريزد مايكرو نيوترينت ريكوايرمنتس، ودي مهمه جدا في تريس اليمنتس اند فيتامينز، مهمه جدا في الهيلينج اوف وونز، وبارتيكولرلي الووتر سوليبل فيتامينز لان هي ما بتبقاش ستورد الحقيقه، بارتيكولرلي بي ان سي. الفيتامين دي كمان فيري امبورتنت، تريس اليمنتس زي السيلينيوم زنك اند كوبر، وعشان كده اتس فيري امبورتنت جايد لاينز بتقول انك لازم ندي supplementation of multivitamin and trace elements very early in the nutritional care of these patients. As regarding the fluid supply طبعا ده بيبقى arranged مع زمايلنا في الاي سي يو ان احنا في special energy supply for children. We have to calculate according to the body weight. و بنكونسيدر الحقيقه حاجتين كانوا موجودين هما الاثنين في حمزه، الفيفر و we have to adjust for the fever and for the urine output to reach at least 1 ml per kg per hour. As regarding monitoring, we have to monitor daily clinical assessment. نشوف البيشنت لو dehydrated، لو there risk of infection، الفلويد بالانس زي ما قلنا، البلاد شوجر very frequently sometimes 2 hours every 2 hours or 4 hours، hemodynamics, electrolytes and correction, kidney functions, nutritional intake, is it decreasing or stabilized, and nutritional complications. Also the weight is very important. important although ان في fluid derangement في fluid status ولكن برضه الفولو اب of weight is very important. اخر حاجه هنتكلم فيها هي النيوتريشن افتر ديسشارج و this is a very important point انه مهم جدا ان البيشنت يكمل بعد ما يخرج من عندنا على adequate nutrition after discharge لان لقينا ان البيشنتس الهايبر كاتابوليك او الهايبر ميتابوليك ستيت اللي بتبقى موجوده extended for months up to 1 year in extensive bursts it can reach up to 2 years. That's why patients should regularly weigh themselves او طبعا لو child the mother have to follow the weight of her child الجروث chart بتاعت الchild. لازم البيشنت في الفولو اب يكون burn patients لازم يبقى فيه nutritional assessment واحنا ادينا advice لمامة حمزه ان هم لازم يفولو الويت وان هم لما يجوا في الاذر يعني في next times they have to come to us. في الادلتس بس حابه اقول ان احنا في another equations we use in the adults like Toronto equation for example. دي one of the methods اللي لقوا انها الى حد ما reliable ومور يعني approachable او قريبه شويه طبعا مش زي الدايركت كالوريمتري لكن دي لما بيبقى عندنا عيان adult sometimes بنبتدي بالويت based calculations بندي بنحاول يعني اللي هي بتبقى على حسب البيرن اريا لو اقل من 40% او اكثر من 40% وبعدين بنبتدي نحسب التورونتو ايكويشن وندي according to it. اخر حاجه هقولها ان اتس فيري امبورتنت ان احنا ندي early nutritional feeding سواء كان في الادلت او في الchildren والافتر discharge involves both children and others. Thank you very much.
شكرا. حضرتك بس كده كذا حاجه بس دي كانت رسالتي بقى في الدكتوراه. اتفضل. كذا حاجه. اول حاجه عشان نحمي الناس كلها عشان ما اعرفش كنت كده مع حمزه ولا لا الامبيانت تمبريتشر.
معلش
يس
الحقيقه
جدا جدا لازم العيان 28 31
صحيح.
طبعا نروح تحت التكييف على العيان وراسه سخن وطبعا ده خناقه مع التمريض ومع التخدير ومع اهل العيان ده سخن تسيبه العيان ونقول نفتح التكييف دي كارثه.
صحيح.
قلنا ان الهايبر ميتابوليزم لازم العيان يبقى بحراره 28 قاعد حران عشان يعرف كويس. تاني حاجه اليورين نيتروجين. احسن حاجه فيها البروتين احسن من الفورمولاز كلها. هل الجماعه اليورين تشوفوا البروتين بتاعه اليوريا فيه
بس عشان التايم الحقيقه ما قلتش يس احنا بنعمل يس فيري امبورتنت والحقيقه هنا في بوينت بقى خاصه بالبيرن بيشنتس ان احنا يوجوالي في اليورين اليوريا نيتروجين احنا بنجمع اليورين طبعا وبنشوف النيتروجين وبنزود عليه 4 و 2 to 4 according to this. في العيانين البيرن بقى احنا اليوريا نيتروجين بلس 4 بنضربه في 1.25 علشان الاكسوديشن اللوسز فروم ذا اكسوديشن فروم ذا وودز فاحنا عشان يبقى مور بيرسنت.
في فورمولا اسهل بكتير كورالي فورمولا.
نعم.
كورالي فورمولا
يس
اسهل بكتير اللي هي مش
بس اتس اوفر الكورالي دي فيري اولد فورمولا الحقيقه لا انها بتوفر استيميت
الناس قالها هيبقى كده سيمبل. اخر حاجه عشان الشخص لو انا ماشي كويس ولا لا الانفكشن احسن حاجه لو في هيلينج كويس لو في كنترول الانفكشن دول احسن حاجتين.
لو في
هيلينج
يس كورس
ما فيش انفكشن بزود
طيب يا ولد
طيب يا دكتور يعني انت بس بتسال
انا عملت الجلسه النيوتريشن كلها الناحيه الثانيه عشان خاطر الدكتور عمرو يعني بس برضه هو معناه ايه بقى؟
شكرا جزيلا.
دينا
ايوه كنت حابب
لا اتفضل
حضرتك اتفضل.
ليه ما تقدمها ضيع الوقت بتاعنا عاجبك كده يا واد.
طبعا حاجه مهمه جدا جدا.
تسالها
10 دقائق.
I'm Dr. Nancy Shahta-Ali, consultant of physiotherapy in the burn unit. I'm very proud to be part of our multidisciplinary team. Thank Mushira. I will discuss Hamza. 1 year and 7 months is called burn, TEPSA on admission 45%, with burn in the area in left upper limb, buttocks, abdomen, and back. Our treatment goal in Hamza is to obtain ideal balance between movement and protection, to achieve full movement without compromising the healing state, to return the patient to his normal function and life before injury. We follow this road map in recovery with close communication with our multidisciplinary team, and create awareness with his parents, yearly physiotherapy from the first day of admission, continuous mobility, splinting, physiotherapy under general anesthesia or sedation in the ICU, occupational therapy, and now we follow him in our outpatient clinic. So we were able to help him to restore his normal life. قدرنا نشوفه امبارح ولد بيتحرك، قادر يمسك، قادر يتحرك، عدينا بيه الجزء اللي نخاف عليه، وهو دلوقتي قادر يعيش كطفل سليم. طيب من هنا ايه هو الفيزيوثيرابي وايه الرول بتاعنا في البيرن هنا، وقد ايه هو مهم وقد ايه هو انتجرال بارت من التيم ده لازم يشتغل عشان يوصل العيان للنهايه ويقدر يعيش بوظيفه طبيعيه. Restoring normal daily function after a burn injury continue to be one of the great challenges in burn management to both of surgeon and therapist. A lot of surgical techniques and rehabilitation protocols have been described in order to improve functional results. With the improvement of medical science, mental healing, life-saving are no longer the only goal of burn care. The importance of deformity prevention, functional restoration, aesthetic improvement, return to family and society has become more apparent for patients, families, and burn caregivers. Burn can leave the patient with severe debilitating and deforming contraction, which can lead to significant disability when left untreated. So, rehabilitation is an integral component in the management of patients with burn and should be commenced from the first day of admission and continue to months or years after discharge. But we face a lot of challenges, which is pain, impaired mobility, debilitating contraction, deformities, scarring, prolonged hospital stay, psychological issues, low resources, and the lack of awareness. Problem solving. Firstly, we need to communicate. The successful rehabilitation of the burn survivor requires involvement of our multidisciplinary team from the first day of admission in order to complete patient context need. It's helpful for surgeon to inform therapists about cause of burn injury, location, depth, extent of burn injury, date of injury, date of admission, type of surgery, site of graft, either recipient or donor side, associated injury as fracture, inhalation injury, and other particular concerns regarding to the medical condition of the patient. It's very helpful to have access to photos of the burn wound at time of admission and for each tracing. All of this information help to estimate the extent, depth, and condition of the burn injury and thus develop a rehabilitation program according to each patient in a safe and effective manner. So continuous communication between surgeon, therapist, and other member of multidisciplinary team to discuss every patient in deep details is an integral corner in the burn management. The second corner is the family communication. It's important to provide education about post-burn rehabilitation protocol to both of patients and their caregivers in order to encourage their compliance with treatment mainly in the first few weeks. Proper timing. Physiotherapy should start on the day of admission and may continue to months or years after discharge. Together with the surgeon, therapist observe and periodically assess the wound of the patient and form a baseline rehabilitation plan and following the patient through his protocol before and after discharge from hospital. Finally, the patient is encouraged to join social networking activities to help regain confidence. Our role of physiotherapy in the burn unit to maintain range of motion, minimize development of contraction and impact of scarring, prevent deformity, maximize functional ability and recovery, maximize psychological well-being, maximize social integration, and enhance quality of life. We follow our way of success about 2 stages, yearly state and later state. Yearly state, it is a wound healing state. We provide respiratory care, edema control, pain control, stimulation of wound healing, maintain range of motion, prevention of contraction and stiffness, prevention of DVT, prevention of pressure sources, maximize functionality and recovery, maximize psychological well-being. Firstly, respiratory care. We need to remove lung secretions, normalize breathing mechanism, prevention complications such as pneumonia, especially in patients with inhalation injury. That's why deep breathing exercises, vibration, percussion, postural drainage, coughing, and suctioning. Then, edema control. Edema control can be prevented by simple elevation, compression, or rhythmic movement from the first day of injury. Then, pain control. Pain control has been considered to be one of the great challenges that can disturb function restoration and impede the process of burn rehabilitation at all time intervals. So, we need to avoid pain during physiotherapy sessions by physiotherapy under general anesthesia or under sedation in the ICU, playing with toys for pediatric patient, mobile gaming for hand burn patient, video gaming as virtual reality, and music therapy. Virtual reality-based burn rehabilitation improve the performance of burn patient, increase range of motion gain in the joint, reduce the intensity and time spent thinking about unpleasant pain, increase fun in rehabilitation therapy, reduce anxiety caused by treatment. Then, exercise therapy. Prolonged hospital stay coupled with persistent skeletal muscle catabolism response after severe burn trauma lead to a state of general deconditioning of burn patient. So, exercise therapy help to enhance glucose control, enhance insulin sensitivity, improve cardiovascular fitness and level states, control blood pressure, improve blood muscle strength or endurance, and enhance stimulation of amino acid into muscle protein and increase lean body mass. Contraction control that can be prevented by proper timing of physiotherapy, proper positioning, splinting, either static or dynamic, active and passive range of motion, and gait training. Ambulation and mobility. It's helpful to prevent DVT, prevention of pressure sources, improve balance and proprioception of these patients. Functional recovery. Matter of importance is to encourage patient from the first day of admission to use his hands as a daily routine from the reception of the hospital. But we need a chance for immobilization in case of concomitant injury to a tendon or burn or bone injury or skin grafting. In this case, we need to put a hand or axilla or elbow or every joint in grafting state in an anti-deformity position with splinting to minimize contraction. Late state, our aim is to improve muscle strength, improve endurance, improve balance and coordination, scar management, engaging patient in functional activities, and the integration into society. Strength and endurance. That's why therapeutic exercises and hydrotherapy, especially when the patient has marked pain or fear from movement, that help to maintain and improve range of motion, enhance muscle strength and endurance. Burn scar formation has been considered to be one of the great challenges in burn rehabilitation that can disturb functional restoration, and so our goal to prevent scar adhesion between superficial and deep tissue. That's why surgery with moisturizing cream, silicone sheet, pressure garment, shockwave, and laser therapy. Society integration. There are barriers that impede the return of patient to society other than the physical conditioning. That's why depression and anxiety, which are major causes of psychological illness that can affect the individual post-burn injury. So we need to focus on the psychosocial aspect of rehabilitation, which is help to ensure the optimal reintegration in a limited resources environment. Attention must be paid not only to the physical aspect, but also psychological aspect of rehabilitation. Our patient needs support, encouragement, and love throughout their rehabilitation trip. Therefore, they can return to life independently, productively, successfully, and happily within their community. Many stories of pain we have lived through, and we are able to overcome them together. So coming back with patient with normal life is impossible. So we have certain prerequisites of successful burden rehabilitation, multidisciplinary team cooperation, patient willingness and understanding to participate in the rehabilitation program, proper rehabilitation protocol, proper timing of burden patient rehabilitation, supple joint, wound healed without too much edema or scar formation. So multidisciplinary burn team that's dedicated to securing the patient's physical, psychological, and social well-being is crucial point to ensure the burn victims can return to his family and work and their society and lead a long, fulfilled life. Thank you.